Today's discussion focuses on culture and its impact on disability and the health services. My name is John Stone. I'm on the faculty of the State University of New York at Buffalo, specifically in the Rehabilitation Science Department, which is in the School of Public Health and Health Professions. I also direct the Center for International Rehabilitation Research, Information and Exchange, which is a federally funded project which facilitates the sharing of information and expertise between the United States and other countries in the area of rehabilitation of people with disabilities. And in that capacity, we've been developing a number of resources related to the cultural perspectives of foreign-born persons in the United States, persons with disabilities. I was a Peace Corps volunteer in India back in the late 1960s, and that's probably where I first started getting exposed to cultures other than my own. Subsequent to the Peace Corps service, after graduate school, I worked in Brazil for about 17 years. So again, culture is kind of part of who I am and what I've been doing the last few years. Today we're going to have a conversation about providing culturally competent services for people with disabilities. The focus is on disabilities, but I believe that most of what we're going to talk about will be transferable or relatable to the health services in general. I'd like to begin with some information about people with disabilities that I presented at the Disparities Summit that was sponsored by the National Institutes for Health late last year. And in that summit, I presented some information from the World Report on Disability. The World Report on Disability was developed and published by the World Health Organization and the World Bank in the late in 2011. That report covers a number of areas divided into different chapters, one of which was a chapter on health services for people with disabilities. And I think some of that information will provide a context for some of our discussion on culture and disability. So let's begin with prevalence. How prevalent is disability? The general results from the World Report cite almost 16% of the world's population as having some form of disability. That represents about 1 billion people. Now these estimates were the first estimates in 40 years, and the previous estimates, we believe, probably underestimated the prevalence of disability. So about 17% worldwide, about 2.2% with very severe disabilities. The rates are generally higher in poorer countries, and the rates are higher among vulnerable groups, such as the poor, women, and elders. So this represents a very significant proportion of the people with special health care needs. In comparison with people without disabilities, persons with disabilities tend to have worse health, lower educational outcomes, lower economic participation, that is to say, higher rates of unemployment, higher rates of poverty, and higher dependency and lower social participation. Now, Chapter 3 of the World Report addresses health, which is the most relevant section for our presentation today. Chapter 3 presents information about health issues common among people with disabilities and some of the barriers that people with disabilities face in accessing health services. So what are some of the health problems that are common among people with disabilities? Disability often brings with it secondary conditions that compromise health. For example, depression, pain, osteoporosis, and pressure ulcers. Physical activity, so important for health, is often difficult for persons with disabilities. Of course, some disabilities have greater impact on health than others. Some health consequences sometimes associated with disability are premature aging, obesity, some negative behaviors such as substance abuse, a greater risk of violence, greater risk of accidents, for example, falls and burns, and a higher risk of premature death. There are many unmet health needs for people with disabilities. There are needs at the level of health promotion, prevention, and treatment. And here we're not talking about prevention or treatment of disabilities, but rather secondary conditions or comorbidities. For example, in the area of physical activities, gym equipment is often not usable by people with certain physical disabilities. In the area of cancer prevention, taking another example, mammograms often usually require the woman to be in a standing position, which may be difficult to achieve for persons with particular physical disabilities. There is an assumption, even among health providers often, that people with disabilities do not engage in sex or have children, and that impacts on the services related to sexual and reproductive health. Some areas that need to be addressed are accessibility, affordability, availability, and the quality of health care. Some of the barriers to accessing health services are inadequate parking areas, narrow doorways, inadequate signage, external and internal stairs, inadequate bathrooms, and equipment. For example, medical equipment. The example of the mammograms is perhaps a good example of that. Other examples are in the area of transportation and communication. The majority of people with disabilities in the United States say that transportation is a great health problem. They have difficulty getting to the health services. Another example, health professionals who turn their heads when speaking with a deaf person, making it impossible for that person to read lips. Counseling about HIV/AIDS is often not offered in sign language for deaf persons. And written health material is often not available in Braille for people with vision impairments. Another problem is that multiple conditions experienced by people with disabilities means they may sometimes require more lengthy appointments. But the health professionals are not reimbursed for the extra time, and this creates disincentives for treating persons with disabilities. Not all health professionals are fully prepared to treat people with disabilities. The curricula of programs in the health professions is often deficient about health care for people with disabilities, and as a consequence, health professionals often lack the knowledge and skills related to the primary and secondary conditions common among people with disabilities. And they may share some of the assumptions of the general population about persons with disabilities, for example, that persons with disabilities are not sexually active. So there are some challenges for the health system in providing services to people with disabilities. An additional layer of challenge arises when the patient is from a different culture than that of the provider. So now we're going to examine some of the ways in which culture can have an impact on the health services for people with disabilities. Much of our discussion will be equally relevant for patients who are not persons with disabilities. Much of what we will discuss in this part of the presentation was developed over the past 10 or 12 years by the Center for International Rehabilitation, Research, Information, and Exchange at the State University of New York at Buffalo under a grant from the National Institute for Disability and Rehabilitation Research. And there's a section of our website that contains a number of resources on culture and disability. One of them is a series of monographs on the cultures of the principal countries of origin of recent immigration to the United States. The focus is on cultural perspectives on health, disability, and rehabilitation. And those monographs became the basis for a book published by Sage Publication in 2005 titled Culture and Disability, Providing Culturally Competent Services. How large is the immigrant population in the United States? Let's start by taking a look at the growth of the immigrant population in the U.S. In 1970, only 5% of the U.S. population was foreign-born. By 2010, that proportion became 13%. So 13% of the U.S. population born outside of the U.S. in other countries. In New York State, it's 22%. And our neighbor to the north, Canada, has a foreign-born population of 18%. And Toronto, the Greater Toronto Area, has a population of 44% born outside of Canada. Where do these immigrants come from? What countries and regions of the world? This is an important question because it will imply different cultural perspectives. This slide shows the distribution of the foreign-born population by region of birth since 2008. Whereas in previous periods, most immigration was from Europe, immigration in recent decades has been from non-Western regions. This slide shows the regions most represented in immigration since 2008. Asia is by far the most represented at 40%. Central America is next at 25%, and that includes Mexico. The principal countries of origin of all U.S. residents born outside the United States are these, with Mexico and China being the largest by far. So why is this important for health and rehabilitation systems? What difficulties do these immigrants face? First of all, our systems are rather complicated. We all know ourselves, even those who grew up here in this country, that we often find it difficult to navigate the health system or the rehabilitation system. And in the case of the immigrant, he or she does not even know sometimes that these services exist because they don't always exist in their country of origin. This is particularly true of rehabilitation services. Also, the objectives of the system are often at odds with the culture of the immigrant. And of course, language is always a significant difficulty faced by new arrivals, depending, of course, on where they are immigrating from. In what ways does culture influence the way we see the world? Well, culture may influence people's understanding of the nature of illness and disability, their causes, and what to do about it. What to do about it meaning treatments, compliance, role of the family, and the concept of independence. In order to work effectively with persons from other cultures, a service provider would need to understand their perspective and explain the services in a way that would be at least partly compatible with their thinking about health and disability. A benefit for the provider of understanding culture is that it may be possible to hint at paths within the patient's own belief system that would lead to more effective outcomes. Although this slide is somewhat oversimplified, most cultures tend toward a more individualist or collectivist worldview. The two columns represent somewhat different value orientations. So for the example, the culture of individualism values self-autonomy, self-orientation, personal goals, views the individual as unique and independent, values individual privacy, tends towards a nuclear family structure, focuses on individual rewards, and values competition. A collectivist culture, on the other hand, values the group unity, group harmony, group goals, values conforming to the group and being interdependent with other persons, group belongingness. The extended family is more common in these cultures. An equal distribution of rewards is a value, and cooperation rather than competition is favored. A second way of describing contrasting worldviews is through the doing versus being prism. And we see this in the two columns of this slide. The doing orientation is basically valuing getting things done. It is an achievement orientation. We need to get things done and done on schedule. An activity is no good unless it has a result, a product. So all problems have to be solved, and we believe we can change things. In the being orientation, what we are is more important than what we do. What we do is the result of what we are. In the doing orientation, what we are is largely a result of what we do. We are defined by our activities. For example, what do you do is always something, a piece of information we want to know about a person we meet. Well, this all may seem rather abstract and not very real world, but as a young Peace Corps volunteer in India in the late 1960s, this cultural difference came crashing down on me in a very real and personal way. I was supposed to survey land for agricultural development in a new irrigation project. I was intent on changing the world, but I only had 2 years to do it. I had to get things done, and I was impatient with delays and missed appointments. I vividly remember one hot day when I was surveying a field at the request of a farmer. It was a large field, it had snakes, and it was hot. We laid out the field on contours and placed wooden stakes in the ground to determine the contour lines for the rice paddies. A government bulldozer was coming the next day to level the land according to the stakes I had laid out. I arrived the next morning, and lo and behold, there were no stakes anywhere. It seems that the women of the village had gone out to collect firewood that morning, and they found these wooden stakes which someone had kindly left in the ground, and there went my surveyed field. I was frustrated and furious. I had wasted the whole day in the sun, and worst of all, there was no outcome. There was nothing to show for it. My activity, therefore, had no value. I was boiling with frustration and anger. The farmer, on the other hand, who owned the field, was more sanguine and suggested that I calm down over a cup of tea. He appreciated my goodwill and effort in spite of the lack of the planned outcome. For him, what I was more important than what I accomplished. My orientation was doing, his was being. I also remember a Peace Corps trainer for area studies training, which was basically, the area studies was basically about Indian culture. And he told us that the most important area for area studies was the area between the right ear and the left ear. And by that he meant self-awareness of our own culture is at least as important as understanding other cultures. So what is the culture of our health and rehabilitation system? What are its values and missions? What are considered successful outcomes? One author defined rehabilitation as services and supports that enable an individual to be as independent and productive as possible in the community. Note the emphasis on the individual and on independence and productivity. Sounds like the individualism worldview and a doing orientation. Guiding principles of rehabilitation, according to this author. Self-determination. The person is at the center and controls the rehabilitation process. Belief in the capacity of individuals to persevere and rise above obstacles. Again, sounds like the doing orientation. Other principles of rehabilitation that are mentioned in the literature. Motivation for good. Belief that individuals are capable of changing and will naturally desire to improve their situation. Influence of the environment. Focus on rehabilitation activities in modifying the environment. So again, change being at the center, wanting to change things, improve things. Now, there are different cultural views of disability, how it is defined, what are the causes, and what should be done about it. How is it defined? Well, in some places, in some cultures, people with disabilities might be lumped within that group of people deemed the misfortunate. So by chance or bad luck, they're just destined to be part of that group. In the West, we have tended to define disability as a pathology, a medical problem. Although more recently, disability has been redefined as its central characteristic being an activity limitation, and that is how the legal definition that the Americans with Disabilities Act uses. Still others, taking a more social view of disability, sees disability as being a characteristic of the environment, not the person. So the person is not able to perform certain activities, not so much because of inherent characteristics in the person, but rather because the environment, the physical and social environment has created barriers to participation and activity. So within that view, disability, society is disabled, not the individual. So there are different perspectives and different ways of looking at the experience of disability. So in our culture, we have tended to link disability to biomedical causes and more recently to barriers that society has placed on people with disabilities. But other cultures have considered disability to have divine causes. For example, the will of God, punishment for sins, or folk explanations such as the mother eating something during pregnancy that caused disability, or a curse, or someone casting the evil eye. So people's responses to disability are influenced by what they see as the cause. They may attribute disability to an individual. They may attribute disability to a negative interaction with the natural world, a negative interaction with the social world, disability as deemed by God, or other spiritual or supernatural factors. So these are some of the ways in which people respond to disability. If we think the physical and social environment are disabling, then we might work to change attitudes and remove physical and social barriers. Additional responses might be self-help or seeking help from others. If we think it is just the divine will, then the response might be acceptance, seeking protection, and not really taking much action about it. Somehow the health professional needs to be able to bridge the gap between the culture of the U.S. health and rehabilitation system and the culture of the foreign-born patient. Let's face it, we can't be knowledgeable about all cultures. And even if we could, individuals within those cultures are very different one from another. But health professionals are experts at assessing. They know how to do assessments. What we're suggesting here is that in some cases, perhaps a cultural assessment might be added as an additional element. Patients construct their own explanation of their disabilities. service providers are not always aware of these explanations. The assumption frequently made by the service provider is that patients understand the causes of their disabilities and the types of services they need in the same way as the providers understand it. This is frequently not true in the case of cross-cultural environments. More than 40 years ago, Dr. Arthur Kleinman, a psychiatrist and medical anthropologist at the Harvard Medical School, realized that the medical students and residents he was teaching did not understand how their patients perceived their illness. He also noticed that patients did not always agree with the treatment that was prescribed. Kleinman developed a useful tool for providers to help them to elicit from their patients their understanding of their condition. The approach developed by Kleinman consists of a series of questions that require the patient to express their understanding of their condition. The following list of questions that might be asked by rehabilitation service providers to elicit the patient's explanatory model. The questions have been modified from Kleinman's question to make them more relevant to persons with disabilities, and instead of the term disability, the provider might make the questions more specific to the individual by using terms like mobility impairment, vision impairment, hearing impairment, or others. So the assessment interview might go something like this. The next few questions will enable me as a service provider to understand your ideas about your disability, how it affects your life, and the types of services you think will best meet your needs. Do you consider yourself well or ill? What do you think caused your condition? How does your disability affect your everyday life? How severe do you consider your disability to be? What have you or others done about it? What kind of services do you think you should receive? What is the most important result you hope to receive from the services at this facility? What are the chief problems caused by this disability? What does your family think about this disability? How does this disability affect your family? What do you fear most about this disability? These questions attempt to elicit the patient's understanding of the etiology, symptoms, treatment, and the interaction of their disability on their social and cultural environment. In understanding a disabled immigrant's state of mind, we might also need to take into account factors such as we see in this slide. For many immigrants, immigration was a choice for which they planned and anticipated for a long period of time. Others, such as refugees, may have been forced to leave their country and did not really choose to be here. Adaptation to new surroundings and a new way of life takes time, and some immigrants may be further along in the process of adaptation than others. Some may be still experiencing culture shock. Depending on how and when they acquired their disability, they may have adapted to it, or they may not yet have accepted it. So factors such as these also need to be taken into account by health professionals when communicating with patients. The next part of this presentation will focus on culture brokering as a way that health professionals might look at their role in working with patients from other cultures. A faculty member from the School of Nursing at the State University of New York at Buffalo, Marianne Jaszewski, did considerable work on this concept as part of her work for her doctorate in anthropology. Much of what follows will be from her work. Dr. Jaszewski defined culture brokering as the act of bridging, linking, or mediating between groups or persons of different cultural systems for the purpose of reducing conflict or producing change. I guess we're all familiar with the term broker, as in real estate broker or stockbroker. The broker is someone who knows the buyer and the seller and is familiar with the market. So the broker helps the buyer and the seller to come to terms. A culture broker is someone who knows something about both cultures and helps both parties to understand each other. So the term culture brokering first appeared in the anthropology literature in the 1940s and 1950s. It was used by anthropologists who were studying colonial governments in peasant societies. And these anthropologists identified certain persons who bridged both traditions and were of great value to the colonial government and to their own societies. These people were knowledgeable about the two cultures, so they were able to explain to each side what the other side was doing and why. And usually they were members of the host culture who were educated in the colonial tradition. Now these persons were able to, had the power to obtain favors in terms of goods and services from the colonial government for their peasant communities. And they were able to explain the local culture and politics to the colonial officials. So the anthropologists labeled this role as culture brokering. The concept was brought into the literature on healthcare delivery in the 1970s. Healthcare delivery researchers borrowed the concept and applied it to persons who functioned as brokers of healthcare in a variety of settings where patients were culturally diverse. Culture brokers bridged the patient's cultural systems and that of the healthcare system. They were often members of the community, for example, outreach workers to the community, or in other cases, they were providers of health care, physicians, nurses, social workers. And out of this, a culture brokering model was developed. It was constructed based on a series of studies that focused on facilitating health care for a variety of populations, for example, migrant farm workers, the homeless, and others. Here we see Jaszewski's model of culture brokering. Dr. Jaszewski developed a model of culture brokering and how it works. It is basically a problem-solving model with three stages. Identification of the problem or problems. Stage two consists of a series of intervention strategies. And stage three is the evaluation of the outcomes to see if the strategies were successful or unsuccessful. And if they were not successful, then there's a loop going back to one or both of the earlier stages. Perhaps we didn't identify if the outcomes were not successful, then perhaps we didn't fully understand what the nature of the problem was. We need to reanalyze that, or perhaps the intervention that we devised was not adequate or not effective. So in stage one, we identify certain problems, for example, non-compliance, missed appointments, disparities in access or in outcomes, communication difficulties, or conflict. In stage two, interventions are devised to establish trust and rapport and maintain connections between the patient and the system. Some of the strategies involve advocating, intervening, networking, mediating, negotiating, sensitizing, and innovating. Clearly, some of these strategies often overlap. Mediating is the strategy culture brokers use when conflict occurs and a go-between, an intermediary, is needed to resolve or minimize, or in some cases prevent, conflicts between patients and the service delivery system. In the networking intervention, the health provider as culture broker establishes links with other professionals who can provide alternate services to patients. Negotiating is appropriate when culture brokering is needed to reach an agreement. Negotiating involves conferring with the patient in order to come to terms with the patient's perception of need for specific services. This can empower the patient because in order to negotiate, the patient or the provider has to understand the perspective of the patient and have knowledge of the system and thereby function as a true middle person. Innovating involves initiating or making a change by introducing a new idea, a new method, or a new device. Desensitizing intervention is when people in the system are not fully aware of the thinking or values or wishes of the patient. And so sensitizing makes the system aware of the attitudes and feelings of the patient, and vice versa. And it calls for care or caution in service delivery when a person from another culture is involved. So basically it's alerting people in the system to cultural issues that may be at play in this particular case. Stage 3 is the evaluation of the outcome. There is a resolution of the problem or there is not a resolution of the problem. And if the problem has not been resolved, then again we loop back to stage 1 and or stage 2 to reanalyze, to take another look at the problem and take another look at the strategies that we've implemented. Intervening conditions affect all 3 stages. These are the things that make the cultural brokering make this brokering model a culture brokering model. There are conditions that may be present in the patient, in the provider, in the system, or in the situation. There are things that the health professional as culture broker should take into account when analyzing a problem or choosing an intervention strategy. And here we see a list, in this slide, we see a list of examples of some of these intervening conditions that we might want to take into account. For example, communication, interpersonal communication, verbal and nonverbal, that takes place between patients, families, and service providers. And here we also might include the use of interpreters. In the case of a language barrier, who is being asked to translate? And is that translator the most appropriate person to do the translation? Stigma refers to negative beliefs and values one person has for another based solely on label ascribed to the person. So in a particular case, do we see stigma? Is a person feeling stigma, or is the family, is that influencing the way the family is acting or avoiding taking action? Power and powerlessness might be another intervening condition. Power is defined as the ability or capacity to act or function effectively in interactive situations, to control one's own actions and or exercise control over the actions of others. So does the patient feel that they no longer have control over what's going to happen, their destiny? Do they feel that their wishes in terms of activities that they would like to be able to engage in are not being paid attention to by the rehabilitation system? Networks. What networks are available within this context? Networks are established links between the culture broker, service provider, and others in the health services or in the community. Others may have the power and know-how to assist the broker. The broker needs to know who are these others who can facilitate brokering. So sometimes it might not be another part of the healthcare system itself, but it might be others in the community, such as a spiritual leader, a priest or an imam who could be called upon to participate in helping the patient or the person with disability to understand things in a slightly different way. So here in this slide we see the culture brokering model all coming together in its 3 stages and the intervening conditions and the interaction between them. And in this slide we see an application of the model in the case of a girl with intellectual disabilities, what used to be called mental retardation. This is a Hispanic family. Some of the problems that were identified: after numerous missed and late appointments, the daughter is determined eligible for services for her condition. The parents and daughter fail to respond to follow-up meeting for service placement. The rehabilitation counselor recognizes the need for intervention. So what might be going on here in this particular case? Well, looking at the intervening conditions, the culture broker determined that the daughter had been labeled as mentally retarded by the service system. The family had a fear that the government would take the daughter away and place her in an institution or a hospital. The family is poor and the parents speak only Spanish. These are intervening conditions that we're going to take into account. The family wants to care for the daughter and does not want her to work. And the daughter does want to work. She wants to become a hairdresser. But the family thinks that because she has a disability, that it's their duty to take care of her and that it would be shameful for her to be expected to work. There are no bilingual or bicultural rehabilitation counselors in this agency. However, the system can offer flexible funding for different purposes that the counselor believes will facilitate. And the rehabilitation system is committed to diversity. So all of these are factors, positive and negative, that the culture broker can take into account in devising strategies. So the rehabilitation counselor identified these conditions and employed the following strategy. Bilingual, bicultural counselor is transferred from another area office. Sensitivity training conducted within the agency. Information on disability disseminated to the Latino community. So the agency, understanding that the community, the Latino community in their area needed to have more information about the nature of disability and therefore did dissemination and outreach. The counselor introduces the family to other Latino families with members who have disabilities. So here we're getting into some networking with the community. Very often the best explainers of resources and explainers of the nature of disability may be families from the same culture who speak the same language. Often they are much more effective in getting to and communicating with the family than a professional might be. And flexible funding was used to fund attendance at national family conferences. So the outcomes: family receives in-house respite services. The daughter participates in an integrated recreation program. The parents participate in a family support network. So those would be positive outcomes that have flowed from this. Conversely, if there is a lack of resolution, then the outcome would be parents ignore the counselor's request for a meeting. So we're back, in that case, we would be back to square one, and we might need to return and take another look at the problem and perhaps devise different solutions. There's no textbook for becoming a good culture broker, but it is something that we can develop over time. Some of the attributes of a good culture broker are a willingness to be a risk taker, be able to tolerate ambiguity and ambiguous roles, be comfortable functioning at the margins of various systems, the consumer's cultural system and the health care delivery system, and good communication skills. Other attributes of a culture broker are the ability to network, to look outside the immediate system for solutions to problems, effective problem-solving skills, flexibility, and a willingness to learn. In summary, the culture broker functions as a cultural bridge between diverse communities and the mainstream service systems. The culture broker understands how a diverse community's culture differs from the mainstream service system culture. The culture broker can explain nuances and values of one culture to the other culture. And the good culture broker tolerates different views, values, and beliefs. Health professionals are often used to following protocols for diagnoses and treatment. In serving culturally diverse patients, we are often left with very few prescriptive resources. And I'm sure this presentation has been a disappointment for those who are seeking solutions to every problem that we encounter in providing culturally competent care. However, I do hope that some of these ideas we discuss may lead us a bit closer to our goal of serving well our diverse patient population. Let me close with an excerpt from M. Miles from the United Kingdom, who has written extensively about culture, religion, and disability. Miles provides the example of Rachel, a community-based therapist about to make a professional visit to the home of a child with a disability. The family name sounds Indian, and the referral notes that they are Hindus. Rachel wishes to make a friendly start with this family, but many questions arise in her mind. Hindus, what do they believe about disability? Will there be a problem of physical contact with the child? Are there not many different kinds of Hinduism? It's a very old religion, and this is a modern family living in a Western city. How much of the traditional beliefs will they hold? And how much will they think modern? Rachel reflects for a moment that her own beliefs also belong within an ancient religious tradition. Some of her beliefs do not fit comfortably with parts of her professional knowledge and training, so she keeps them in separate compartments of her mind. Is that perhaps what Hindus do? Maybe it would be good to ask them. But you have to be careful with questions of religion, and people are sensitive around disability. And it doesn't really make any difference in what you hope to do with the child. But should it make a difference, maybe? After all, community-based work aims for a partnership between professional and family within the context of the local community. So it's important to learn how the family thinks, assuming that they all think alike. Maybe the child is growing up in two worlds. On the other hand, the family may have been here 100 years already. We left the therapist Rachel a few moments ago wondering about the Hindu family she was about to meet. She was reflecting on culture, change, Hinduism, and uncertainty. By now, perhaps she is asking her client's family a few polite questions. Maybe she is looking for a book about Hinduism. Maybe she finds a quiet place to meditate or pray. Maybe she rejects it all as superstitious nonsense. Maybe she is frightened and retreats inside her own professional persona. Whatever her own beliefs and feelings and practices, the one thing Rachel cannot do is find a world where all her clients and their families have the same culture and the same beliefs about disability, and see a straightforward connection between their culture and their beliefs about disability and health. If Rachel is going to continue to mature as a professional and as a human being, she must swim in the multicultural, multi-religious, multi-ideological ocean of modern society, as do all of us. Thank you, and successful culture brokering.